India is at the epicenter of coronary artery disease. We are the global capital of coronary artery disease. We have more coronary artery disease than any other country on earth. The most common symptoms of cardiac disease that we face in day-to-day practice are dyspnea on exertion, palpitations, and chest pain. Dyspnea on exertion is the breathlessness that one develops with activity. The activity may be of various levels. Some have it with mild activity, in some it comes on only with strenuous activity. By palpitation, I mean the irregularity of the heart rate or the sense that one's heart is beating, which is usually not seen in individuals, but if it is there with minimal activity, that could pertain to a cardiac disease. The most important of the three symptoms that I've listed so far are chest pain or anginal discomfort. Anginal discomfort is pain related to the blood supply to the heart being thwarted to an extent. Now remember that chest pain would only appear if the blockage to the coronary arteries is above 70%. If one has a 95% blockage to the coronary arteries, one tends to have chest pain even at rest. In patients who have a blockade of about 90%, this pain would be brought about by minimal activity. When I say minimal activity, it would mean just scrubbing a floor or taking a vigorous bath. One other symptom that I would like to highlight is patients tend to have chest pain more on a full stomach. So if you have a full meal and you do a minimal activity, one tends to have more symptoms. As also chest pain tends to be more in the early morning hours. This is actually very well documented a fact. And unfortunately for us, when we say coronary artery disease, patients actually present in two ways. One is they may present to the emergency room with sudden onset chest pain. When you have sudden onset chest pain related to the heart, secondary to a myocardial infarction, the best treatment modality is a primary angioplasty. The other treatment modality available is a thrombolysis or a dissolution of the clot. Let me explain further. When one has a blockage to the heart which presents suddenly, the blockage is secondary to a cholesterol block on which blood clots. So when I dissolve the clot, I am re-establishing flow only to a certain extent. It will never be 100% flow re-establishment. Whereas by doing a primary angioplasty, what I am doing is I am removing the cholesterol clot as also I am removing the clot, which is to say that I am able to re-establish the lumen size or the arterial size to 100%. So definitely a primary angioplasty would be the best treatment modality available to a patient who comes with sudden onset chest pain. But remember that this has to be done within a period of 3 hours. The best benefits got are when it is done within 3 hours. Because each hour, we call it the golden hour. If you do it in 1 hour, you're saving or salvaging a lot of tissue. The more the time delay, the more the tissue loss. Why I again pick on this is the brain, just like the heart, does not have the capacity to regenerate. If muscle or brain tissue is lost, it is lost for life. If you have a large myocardial infarction and then go and do a bypass or an angioplasty, you still do not improve as much because the heart muscle is already lost, though you have re-established tissue. So again, coming back, the best treatment for an acute myocardial infarction would be a primary angioplasty, failing which one could still do a primary thrombolytic therapy, which can be done for a period of 6 hours. When I say treatment lifelong, what I mean is at least 2 sets of medicines. One medicine for cholesterol and one medicine to keep the blood thinned has to be continued lifelong. If one is diabetic or hypertensive, corresponding treatment for the same should be added to what one is already on. There are these side effects with medicines. Definitely yes, if a medicine has an effect, it will definitely have a side effect. But the side effect profile is very minimal. It's not common that somebody comes with side effects. Many people tell us that if you have a statin or a cholesterol lowering drug, one may become diabetic, one may have kidney disease. That is seen in a very, very small, minuscule number of people, and that should not prevent somebody from taking medicines. To put things in perspective, if I give 1,000 people a statin, only 8 of them would come with symptoms related to a statin, whereas 992 people would benefit from this. So that benefit is what we are actually focusing on. When we're talking of the preventive strategy, we're talking of 2 levels actually. One, in patients who already have heart disease, and second, in patients who have not had heart disease but who are at a risk for disease. Now, coming to the first subset of people who have already had heart disease, one of the things that I tell all my patients is of a stool with 3 legs. For a stool to have stability, all the 3 legs should be of an equal length. The same way, for a cardiac patient to have stability, one has to depend on the 3 legs of 1, diet and nutrition, 2, exercise, and 3rd, medicines. Medicines alone is not going to treat anyone ever. You have to put in a component of diet and nutrition and exercise also. What should be the exercise modality? It actually can be anything which a patient is comfortable or which an individual is comfortable with. When I say a brisk walk, I mean walking at a speed of 6 kilometers per hour. When I put in 40 minutes of walk, I cover about 4.4 kilometers. That would be ideal for an aged person. For a person less than the age of 50 without any knee problems, he could put in 20 minutes of exercise on a treadmill. Swimming is an excellent means of exercise, but pools are not available everywhere. Jogging too, if it's in a high rise, jogging is also an excellent means of exercise. It can be between a brisk jog of between 12 and 18 minutes, does a lot of good to individuals with heart disease.